Good morning, everyone, and welcome to our 9th National Forum on Sepsis. We here at Sepsis are delighted you can join us from all over the United States and from 38 countries around the world. In the next 3.5 hours, you will hear from leaders in the battle against sepsis. Our speakers are at the forefront of this battle, from political to medical. Our first speaker today is a great friend of ours. He has successfully guided sepsis awareness throughout the United States, from recognition of September the 13th as World Sepsis Day to the allocation of funding to finance federal agencies in their work against sepsis. Without his leadership, there would be no money for sepsis in United States agencies such as CDC, CMS are in their fight against sepsis. He has gone from allocating millions of dollars in the fight against sepsis to now authoring and being a co-sponsor of the Life-Saving Bipartisan Sepsis Act in the United States Senate, S1929. You'll hear more about this later. With that, here is our good friend, Senator Charles Schumer.
Hi, everyone. It's Senator Chuck Schumer, and I'm sure sorry I can't be with you in person, but I am with you in spirit as you come together for the 9th National Forum on Sepsis. First, I want to recognize two of the greatest champions and saints in the fight against sepsis, Kieran and Orla Staunton. After the loss of their beloved son, Rory, the Stauntons didn't just turn inward and curse the darkness. They lit a candle. They turned grief into action. They shared Rory's story in hopes that no family would suffer the pain they endured. And because of their tireless efforts, the Stauntons have changed the way the world understands sepsis. In New York, they passed the groundbreaking Rory's Regulations, which have saved countless lives and serve as a model of what we can and should do across the nation. I've been proud to work together with the Stauntons to make historic progress in the fight against sepsis. Earlier this year, I introduced bipartisan legislation, the Sepsis Act, to provide hospitals with better capacity to detect and treat sepsis. I am working every single day to secure more co-sponsors so we can pass the Sepsis Act through Congress as soon as possible. But we also need more funding for sepsis. That's why I was proud to secure $3 million in federal funding for the CDC sepsis initiatives, the largest funding allocation ever dedicated to sepsis. And to help raise more awareness, I introduced legislation declaring September 13th as National Sepsis Day. But I couldn't have done it without your support. Together, our effort to end sepsis is as strong as ever. You have my word. I'll keep fighting with the Stauntons and with all of you, and one day, hopefully soon, we'll end sepsis once and for all. Thank you. Enjoy the forum.
Thank you, Senator Schumer. Thank you very much. You have been a wonderful friend. Our next speaker is Congressman Donald Norcross from New Jersey's 1st District. He's lucky to be alive today. Congressman Norcross boarded a plane from Florida to Philadelphia in April 2025. Just a few hours later, he was in a hospital in Raleigh, North Carolina, barely conscious and fighting for his life. Congressman Norcross is working with his colleagues across the aisle to have the Sepsis Act, matching the one in the Senate, introduced in the United States House of Representatives. As soon as that is introduced, we will let everyone know. Good morning, Congressman Norcross. We are so glad you survived sepsis. We're looking forward to working with you to get the Sepsis Act introduced in the House of Representatives. And with that, here is Congressman Norcross.
Well, thank you, Corey, for that wonderful introduction. And yes, as I say, it's good to be alive and vertical. And I appreciate very much the opportunity to come on and just speak from a minute, because obviously this issue that we're talking about became very personal for me. We know the raw numbers. 350,000 Americans die each year from sepsis. These experiences that were literally 6 months ago today, when I got a firsthand briefing, shall we say, on what sepsis is. You mentioned that I got on a plane coming back from Florida, as I travel quite often. And while on that plane, something happened. I felt fine, and minutes later, shaking violently. And that was the first step of what I call moments of decision that saved my life. I got up to speak to a flight attendant, and I collapsed on the floor of the plane. Um, at that point, somebody on the plane had to make that decision on this gentleman laying there on the floor. They had no idea who I was, where I was going, but they clearly had a method of determining that this was a problem. And we made an emergency landing in North Carolina, where I was quickly rushed to the UNC Rex, where this is where it really happens, is they detected very shortly after I arrived that I was in sepsis. And quite frankly, as we all know, my organs were shutting down, and they were able to start treatment then. But treatment was further down the road. They had to keep me alive. That following day, I was transferred up to my hometown in Camden, where I spent the next 5 weeks in the hospital. 2 of those I remember very little. And I know I am preaching to the choir here, but my wife just shared with me recently that the first 3 nights, they didn't expect me to make it through. I still get choked up when I think about this, on how by a series of events that finding out with sepsis and then those around me making the right medical decisions, having access to the right medical and hospitals, they saved my life. I will never forget it. So how do we turn that very raw and real situation that I face into a winning combination where we can help that next generation who are going to be impacted by this? Because as we know, age has nothing to do with it, but it certainly has a lot to do with how we educate our professionals. And certainly started on the airplane where they made a decision, those rushing me to the hospital. So we want to make sure that as soon as we come off of this unfortunate shutdown in Washington, that we are going to introduce it into the House. I want to say thank you to Senator Schumer, Senator Collins, and Senator Kim for their part in introducing this in the Senate. Now we need to do our part in the House of Representatives. This is not a partisan issue. It doesn't happen to people in just red or blue states. This is an issue that we can make a lasting impact, saving those families, as we heard today, what they're going through. So the CDC is what we are looking to create, this educational program, and make it much more meaningful for those who have no idea what was going on, as I didn't, had no idea. So New Jersey has these guidelines. We want to make sure that every state in the union has the guidelines, getting the feedback from CDC. So I am absolutely thrilled to be alive, be with you today to share that story, and more importantly, how we can turn that pain into something very positive by passing this bill and have it signed into law. So thanks for being here today, and together we can end sepsis. Thank you.
Thank you very much, Congressman Norcross, and we look forward to working with you, and we would look forward to making history, passing the first ever sepsis legislation in the United States, and we are going to arrest that killer in our midst. Thank you very much, sir. Thank you.
Take care.
Our sponsor today is Northwell Health. Northwell Health is the largest healthcare system leader in the United States, and it has the gold standard in sepsis healthcare. We congratulate Michael Dowling on the recent announcement of his retirement, and we wish him well. None of our work on sepsis would have been possible over the last 13 years, but for Michael Dowling. We congratulate Dr. John D'Angelo on being announced as Northwell's new president and CEO. We have worked with John since our very first visit to Northwell many years ago. We know him to be just like his predecessor, to be a fighter against sepsis, and we look forward to working with him in the future as we attack this killer in our midst. Orla and I are the founders of In Sepsis, the legacy of our wonderful son, Rory Staunton, who died in 2012 at 12 years of age from undiagnosed and untreated sepsis in the great city of New York. Since Rory died, over 3 million Americans have died from sepsis. Most of those deaths, like Rory's, were preventable. Rory's life could have been saved. Rory Staunton's death was totally preventable. But, as Senator Schumer said, we didn't take Rory's death lying down. We organised. We mobilised. In Sepsis has been the leader of transforming a national policy ensuring that federal health agencies and Congress recognise sepsis as the public health crisis that it is. Rory's regulations in New York saved over 16,000 lives in its first 4 years. And since it has become law, a version of Rory's regulations have been introduced, have been passed in many states, covering over 50 million Americans. But we have much more to do. In Sepsis we have much more done. Sorry, before we get to that. In Sepsis successfully led the campaign for sepsis core elements by CDC. In Sepsis persuaded the White House last year to have its first ever sepsis event, an event that was opened by Orla Staunton. We were responsible for ARC receiving funding to produce a congressional report for Congress, the first of its kind that enabled it to put sepsis on its national agenda. After 13 years of work, coalition building, pressure on federal agencies, the breakthroughs are finally coming. We have got results. We have saved lives. And we will continue to lead the battle against sepsis. We have now succeeded in getting both parties in the United States Senate to introduce the Life-Saving Sepsis Act, a bill that is gathering momentum, Bill number S1929. This is a bipartisan legislation. It is the support of Senator Collins, Senator Schumer, Senator Kim, and some others. But there is a willingness from people on both sides. Plus, we have endorsement from many organisations, national organisations, such as the American Hospital Association, the Federation of American Hospitals, our friends at Sepsis Alliance, the Infectious Disease Society, and many more. However, we need everyone's help because the interesting thing is this life-saving legislation is in the hands of 11 senators. 11 senators, 9 men and 2 women get to decide whether or not we will have life-saving legislation passed. And we need your help. And it cannot be done alone, because if you look what we achieved on our own, we got 16,000 lives over 4 years saved in New York State. But imagine what everyone here today, everyone watching, and we all join together, Tríla Céile, as we would say in our native language. We can stop this. We can arrest it. We know how to do it, and we have the friends to do it. So what we are saying is, everyone, we must roll up the sleeves and do it. Since our forum last year, 350,000 Americans died of sepsis, mostly preventable deaths. This needs to stop. And working together, we will stop it. We need you to contact your senator and tell him or her, ask him or her to co-sponsor S1929. Or go to our website if you need, or call me directly, 917-251-0000. 0739. We need your help saving American lives, because this issue isn't Republican or Democrat. When we went out to buy a coffin, like many other parents, no one said, do you want a Republican coffin or a Democratic coffin? 350,000 people last year bought coffins, unnecessarily most of them, because enough wasn't done. Before I hand you over to Dr. Martin Dorfler, I just want to mention there's an upcoming book coming out on sepsis. You can find out on more details at bloodpoisoning.com. I also want to mention that I want to thank Sabine Horner for her extraordinary work on the forum. She has left no stone unturned, making everything a success today. And finally, I want to introduce you to someone who has walked the halls of Sepsis Change with us. He has been with us from the start. Within Sepsis is proud to have him as our medical advisor. He takes our calls around the clock and gets back to us. And now let me introduce and welcome Dr. Martin Dorfler. Thank you very much.
Hello, everyone. Thank you, Kieran, for the kind introduction. It's my honor to be your moderator here today for the 9th National Forum on Sepsis. We've got a phenomenal expert panel, set of expert panels today. I'm looking forward to hearing from all of them. The first panel is going to talk about new legislation and policies. We're going to hear some important work on communication. Kieran did not mention one of the issues in the care of Rory was the dropped ball of communicating what was necessary to follow up and see whether or not he had real issues or not when he was sent home from the emergency department. And then we're going to, and this is an important note for folks, the next couple of slides get into the CME on this. There is continuing medical education, and I'll talk to those when we move to those slides. But the second two panels have industry representatives, and is everyone familiar with the CME process, industry representatives as part of the conversation, just by the nature of their work, the CME process doesn't allow the granting of credits for that time. So we're going to switch links midway through the 4 panel discussions. And we're going to hear in our third panel some of the things going on with AI changing the approach to care and having the computer help providers in identifying and driving the care of sepsis. And then we're going to have another panel with some additional new science and new approaches to the diagnosis of sepsis, bringing forward work that's been going on literally for decades to try to better understand the underlying biology, pathophysiology, and to identify markers that might be helpful for us there. So if we could go to the next slide, review through the quick continuing education credits. This forum is by Northwell Health designated to provide 2 AMA Category 1 physician credits and 2 ANCC contact hours. Verification of attendance will be provided to all professionals. There will be an outcome survey on the next slide sent out to you around 3 months after this to validate your participation. And then lastly on this, the disclosure policy, all of the planners and speakers in the first 2 sessions have nothing to disclose. And with that, I'd like to move forward to our first panel discussion, which I think is going to be very interesting. We unfortunately, because of the shutdown, don't have representatives of CMS and CDC who were hoping to be here with us and update on some of their work, but we have a wonderful group of professionals here, and I'll let each of them introduce themselves when their piece comes up. Ray Dantes from Emory, Aiken Demahan from the American Hospital Association, Mark Sands from Northwell Health, and Foster Geston, formerly from the New York State Department of Health. So if we can move to the panel and bring out Dr. Dantes. Ray, I'll let you say something about yourself and then jump in and set the stage here for us on what to expect with the evolving CMS measures and the approach the CDC is taking of late in helping to drive improved care of sepsis. Ray?
Thanks, Martin. Appreciate the introduction there. So my name is Ray Dantes. I'm Associate Professor of Medicine and the lead for the Emory Healthcare Sepsis Program. I've also worked for many years as a medical advisor to the CDC. We'll discuss briefly here some of the future federal sepsis quality measures under development. Just want to lead with the disclosure that while I have served as a medical advisor for the CDC for many years, the presentation today is my own and don't represent the views of the CDC or the US government. Right. So that said here, I want to lay out a simple illustration about where quality measures line up with the patient experience with sepsis. So the average hospitalization for a patient with sepsis for adults is about 8 days. Right now, there's a lot of focus on the existing SEP1, that's the early sepsis management bundle that is reported by the vast majority of US hospitals. But that is the current, that is what we got right now for federal quality measures. But under development right now, we have a sepsis outcome measure that I'm going to discuss, a sepsis readmission measure, and a sepsis program or structural measure that that evaluates the underlying structure that supports sepsis care throughout the hospitalization. We'll spend a few minutes discussing the sepsis outcome measure, and I'll try not to get too much into the weeds here. All right, you may be first wondering why we don't have a sepsis outcome measure already. Well, there are some challenges with defining a sepsis outcome measure. The relying on diagnostic coding is subject to a lot of variable coding practice, variable awareness, and financial incentives for billing for sepsis. And so there is a need to define sepsis very objectively using reproducible criteria. And then the other big challenge for a sepsis outcome measure is risk adjustment. So I like to look at the field of quality measurement as like standardized testing for a hospital. And with sepsis, no two patients are alike. You know, there are some patients who come in very sick, critically ill, and are facing a very uphill battle. But there are also folks who kind of just sneak in and who have kind of less acute sepsis, come in earlier in their course. They have infections that are less severe, that have a much better prognosis. And every hospital is going to see a different mix of those kinds of patients. And so we need to have very, very robust risk adjustment to account for that if we're going to have a good sepsis outcome measure. All right. And so the CDC has been partnering with CMS and the Harvard Pilgrim Healthcare Group, as well as many experts and patient representatives, I think some that are represented here today, to put together a sepsis outcome measure that was recently proposed for the CMS measures under consideration list. The details are listed here. Basically, it's a hospital level standardized mortality ratio, so the observed amount of mortality and discharge to hospice over what would be predicted based on the data on how sick those folks are when they come in. We won't go over the details of how sepsis is defined, but it relies on a decade of existing literature on defining sepsis for using objective criteria that very similar to what was used for the official accounts that the CDC produces. On this slide here, we have a description of the many variables that will be taken into account for risk adjustment. And all of this is made possible with new data interoperability standards called FHIR. All right, we'll speak very briefly about the sepsis readmission measure. So we know from existing literature that between 17 to 26% of patients who survive their sepsis hospitalization are readmitted in a short period of time. CMS has been leading the charge to develop a readmission measure, and they've contracted with the Yale Center for Outcomes Research and Evaluation. This is a measure that will focus on Medicare fee-for-service and Medicaid patients. I understand the measure is risk adjusted as well, but the full specifications are not yet published. Though I assume that there may be folks in this audience that have been part of that process for producing this measure. And lastly, I'll mention the sepsis structural measure. Right, so a couple years ago at the CDC, they launched the Hospital Sepsis Program Core Elements. And so I like to use the analogy that if the clinical guidelines are like the recipes for taking care of someone with sepsis, the core elements are the manager's guide for running the restaurant. So this is how you support your staff so that they can provide the best possible and most efficient care for patients with sepsis. So that includes an emphasis on leadership support, accountability, multi-professional expertise, action, tracking data, reporting feedback to your frontline providers, and education. The CDC has been asking hospitals about their sepsis programs for the last couple of years using their annual survey that all participants in the National Healthcare Safety Network produce. And so over 5,000 US hospitals have been answering questions about their sepsis program. And this measure basically just turns that into a score, into a measure score. And so, for example, in the 28 priority examples that are listed in the core elements document, this is one of them. Our hospital has implemented a standard process to screen for sepsis on presentation and throughout hospitalization. And to get that point, you have to attest, to the following questions in the annual survey listed here. As I mentioned, the core elements score is a sum of how many of those 28 hospital sepsis program priority element examples that you attest to. And then I just want to let folks know that there is also an audit tool that is under development to support this measure. All right, I'll stop there because I know we have many other presenters here, but thank you for your time and the opportunity to present today.
And thank you, Ray. I really appreciate your setting the stage for this conversation and giving us a handle on both the CDC's work, which is out, and the CMS work, which we're expecting to come out. Mr. Demahan, I'm going to ask you to introduce yourself from the American Hospital Association. And we've asked you to talk a little bit about the Hospital Association's thinking and approach to these measures and the CDC program. If you would take the stage, sir.
Thank you. Good morning. It's really an honor to be with you to talk about sepsis and our efforts to work with our members to address it and the policy environment around it. It was really a pleasure to hear Dr. Dantas's presentation and had the opportunity to work some with him during the development of the sepsis core elements process. And I want to talk a little bit about why that core elements piece was so helpful, and then offer a couple of perspectives on the measurement piece before letting my other colleagues on this panel chat about this as well. As you look at the core elements document, I think there are really three reasons why, as we worked with our members, we found that approach particularly helpful. Number one, it's relevant and actionable to all hospitals. And when we talk about hospitals, we're talking about over 5,000 hospitals across the country, some of which are large quaternary referral centers, others of which are community hospitals that are serving either urban or suburban areas, and some are critical access hospitals of 25 or fewer beds. The goal is to ensure that all hospitals have a program to rapidly identify and treat sepsis. And this is a resource that helps, as Ray was alluding to, kind of giving them a manager's guide to help inform their efforts of doing that. What we know about sepsis has already been underscored in the conversation this morning, and that is that early identification and diagnosis is critical to saving lives. That is a hard thing to achieve because we know that it's not just a single disease and that the early signs of sepsis can present themselves differently depending on a patient's particular circumstances. What the core elements try to do is to distill down the action pieces that every hospital can potentially draw upon. And that starts with, as Ray was talking about, a leadership commitment for ensuring sepsis prevention and detection. Making it a priority really does help to focus attention and to build the internal processes to address it. Secondly, the core elements really do recognize the complexity around sepsis. Given how differently sepsis can present in different patients, it recognizes the importance of bringing together multiple different experts within a hospital to provide a multidisciplinary approach to delivering care. It's a bit like some of you may be familiar with things like code teams within hospitals. It's really this kind of well-oiled team that comes together to act quickly. That's what the real advantage of that multidisciplinary effort is. And then the last thing that I'll note before I say just a couple of words about measurement, the core elements recognize and leave room for some of the emerging innovations. And I saw later on the agenda, there's some conversation around AI. I personally think that is some of the most exciting emerging work over the past several years of being able to use medical record information from electronic health records and to be able to scan it to identify potential early signs of sepsis and to help elevate for clinicians who are trying to make rapid, well-informed decisions about how to deliver care, equipping them with information that they may not have been able to see at a glance. That's really some of the real potential power behind this. As we think about measurement, I would say just a couple of things. Number one, we are very eager to have a sepsis outcome measure. We think in part it really does help focus the work on driving the reductions in mortality that I think all hospitals and health systems want to achieve. It also recognizes the need for hospitals to respond in ways that make the most sense for the patients and the communities that they serve. Given the differences how sepsis can present, given the differences in patient populations, and given the differences in the specific sets of services that hospitals have, an outcome measure can really be a unifying approach that focuses all on the same goal. Secondly, I think Dr. Dantas really noted some of the nuances around it that I know our members will continue to look at as the development of these measures continue. The great importance of having sepsis measurement is around focusing attention. These are measures that do end up as a part of public reporting programs, potentially as a part of value-based care programs. For hospitals, they are always attentive to, are these measures measuring performance in ways that are equitable across hospitals, recognizing the differences in the kinds of patients that they treat. We know that collecting and reporting quality data is a really important activity. It is one that takes resources. And so understanding what it takes to get the data in to calculate that accurate measure rate, I think will be very much on the minds of our hospitals as they look at this. But this is an incredibly exciting time for sepsis and a real opportunity to continue this incredibly important work of ending it. So with that, I will turn it back over to you, Dr. Dorfler. Really honored to be a part of this.
Thank you, Aiken. Really appreciate your comments here, and we're going to get into some conversation around this after we hear from our next two panelists. And our next panelist is Dr. Mark Sands at Northwell Health. Mark, I'm going to let you introduce yourself and then talk a little bit about your work and the approach that your system is taking.
Thank you, Marty. I'm a practicing interventional radiologist, but have stepped into the role that Marty had here at Northwell as the Director of Clinical Transformation and Improvement, which is a group of 26 people that are endeavoring to standardize processes across the health system, but have two clinical foci, the most important of which is reducing sepsis mortality. If you can advance to the next slide. Northwell's been on this journey since 2008, starting with the former CEO, Michael Dowling, who proclaimed war on sepsis before it was much of a national draw. Dr. Dorfler joined in 2011, a few years later, but together with Dr. D'Angelo, our current CEO, began focus on ED recognition of sepsis in patient units, the advantages to addressing fluid issues, redoing order sets, and the like. Last year, I was privileged to join this forum, and we were just on the precipice of a system-wide retreat called Sepsis Reinvigorated. I'm pleased to announce that that last red dot on the graph shows that we achieved our goal several months early, dropping severe sepsis and septic shock mortality throughout the health system to less than 20% for the first time ever. We've been on a continued downtrend, but the particular emphasis last October was around the CDC core elements. Next slide, please. So the CDC core elements, working off the successful framework from antimicrobial stewardship almost a decade before, really laid out to the hospitals and to the health systems what elements needed to be present and how, even though many of these pieces were already in existence, how to focus them on the results that were desired. And for us particularly, this really meant working within the hospital groups that had already laid down independent processes for a lot of this, some sort of standardization matrix. Next slide. And we borrowed from IPSO, the Improving Pediatric Sepsis Outcomes Initiative, of really turning across a very large matrix organization of how to do that. And in the vertical columns, we had the hospitals and the health system that were engaging, as well as the key service lines. And we added two: pharmacy, which was always going to be a determinant in any venue of care where septic patients were, and advancing healthcare for all. Are there opportunities for us to focus on subpopulations within our communities that have differing outcomes? Next slide. Each vertical, each hospital was led by a medical director, a nursing director, and a quality director. But at the same time, we understood that the venues of care, the intersections of those horizontals and verticals, really required cooperation of service line leaders so that ICU care across the health system would be similar, allowing for differences in the size of the hospitals and some of the resources that we're seeing. We set up an accountability matrix, as you see here, which was really, I think, the biggest piece of the core element teachings for us, was how to keep people focused beyond the initial results. And for us, the verticals meet monthly. The hospital leaders meet with their sites. If there's pediatric units in that hospital, they meet with their pediatricians and the caregivers there. If there's OBGYN, they meet there. The service lines, ICU, OB, PEDS, meet with their representatives in each of the hospitals quarterly. And this feeds back into a semi-annual retreat, the next one of which is to be held in another month. But underpinning the whole thing is the group that I'm fortunate to lead, is the clinical transformation group, having routine office hours to meet with the folks who are doing the work and to make sure that they have touch points between the different horizontals so that everybody has the opportunity to learn from the transparent work that's being done. Next slide, please. So part of this was to inspire each of the service lines, each of the care venues, to have 3 separate process chains, IHI style drivers, to work on. And then the next slide, I'm going to try and quicken this a bit, is how to centralize that work: automatic PDSA submission forms, creation of a Microsoft Teams channel, and the office hours that underpin the whole thing. The next slide. And this was all put up on a SharePoint site for every service line, every venue of care to see. Everybody can look into other people's PDSA work and see how it's progressing, what the lessons learned were, whether it's been applied. Next slide. There's the life cycle of the PDSA projects that were being undertaken by each of the venues and service lines. Next slide. And so really the opportunity for us in the last year has been to style improvement work based on the CDC core elements guidelines of who's involved and how information should be shared and how teachings get reapplied. We've progressed to the point now where PDSA models are not the only models that are being used. We're looking at FMEA structures. We're looking at RCAs for venues where the number of cases are smaller, but also continually investing the SharePoint site with this work and then bringing the entire group back together twice a year to share these teachings and lessons. Next slide. It's been a remarkable journey, again, inspired and coordinated through the CDC core elements. Faced many challenges. We've resolved many of them. But I think really the question that always comes up is, in a world where medical priorities and hospital priorities change, how do you maintain momentum when there are competing priorities? And we really feel that the accountability structure that's been set up here is now hardwired into the buildings. It's hardwired into the service lines across the buildings. We've identified champions who enjoy this work, who take the opportunity to share it amongst the sites. And so we think that the work we have, the work we've done is reproducible in other sites. I think we're done, and I'd like to join the conversation.
Yeah, thanks, Mark. Our last speaker before we get into conversation with the group is Dr. Foster Geston. I've worked with Foster for a long time, and he's going to introduce himself, but I'm going to point out that Dr. Geston played a critical role in the New York State regulations that began a lot of this journey and has been a great friend along the way. Dr. Geston.
Marty, thank you so much. And what a privilege it is, an honor to be part of this panel and part of the End Sepsis Forum. Very much look forward to our conversation on this panel and all the rest of the day's events. I just, what a great setup for my talk. Everybody has commented on different pieces of it. So I'm going to talk about it just a little bit more at a different level and talk a little bit about the act itself. But I first want to recognize that every day, the clinicians, the hospitals, the health systems, the nurses, the patients and families that are on this webinar and that are not on this webinar, not able to be on this webinar, do amazing work in an increasingly challenging environment, which was alluded to several times, taking care of patients with sepsis. This legislation is aimed and put together to help support that work. That is the overriding goal of this legislation. And as was mentioned, it's a bipartisan effort that relied upon a lot of input from a number of people, which I'll get to in the last slide. But the overriding goal is to reduce preventable deaths and disability from sepsis, while at the same time recognizing that both the human and the financial costs of sepsis to all insurers, both public and private, relies upon the best science to focus on early and rapid recognition and treatment, consistency and structural elements, as was just discussed by Dr. Sands, to improve the coordination, the all hands on deck, the team effort, the village effort of providing care, as well as trying to improve some of the tools in the toolbox to help those organizations and clinicians know where they are, know how they're doing, be able to learn from other organizations by using a more sophisticated set of both process and outcome measures, not only looking at mortality, but also looking at process and eventually looking at morbidity outcomes as well, which are equally important. These are the overall goals of the Sepsis Act, which, as Kieran mentioned earlier on, was introduced both in the late last session and introduced this session. And the fate of this relies on, I would say, all of us, as well as the key people that are part of the committee and part of the Senate and Congress as well. Next slide. The elements, just to recapitulate, many of these have been talked about in some detail. And you heard from Ray and others about some of the components. But just to put it all together, the elements of this act created a dedicated sepsis leadership team that is HHS charges to be at CDC to coordinate these national efforts. Now, that seems like that should already exist. I guess it seems to all of us that it should have existed a long time ago. But this is a way of formalizing that structure. Hearing somebody needs to mute, I think.
We need to mute anybody not mute the background, please.
The police versus.
I'm wondering if there's a way to mute everybody just temporarily for the folks who are running the webinar, just so this person who's talking obviously is not listening here. Oh, great. The Act also promotes the adoption of best practices, and you heard folks talk about that in terms of the core elements which were developed by CDC in conjunction with a number of clinical inputs, including work that's been done in the state of Michigan. It also importantly focuses on the data collection and includes the collection of data on pediatric cases and tries to update the federal programs that track data to do that better and to be able to report sepsis cases and outcomes and other information about sepsis on an ongoing basis. Kieran talked about the AHRQ doing one of the initial reports, and I think as much as we were all steeped in this information, it was stunning to all of us, and I think to the folks that we presented it to see the full breadth of the impact of sepsis on outcomes, including both personal human mortality, morbidity, hospitalizations, costs, and so on. I think importantly that the Act tries to strengthen coordination. I think we've all been aware various times and in various ways of the challenges of having different federal agencies who have a piece of this work, but don't necessarily have not always historically worked together or coordinated their efforts. We've seen amazing strides in that direction over the past few years. We like to see that continue, but the legislation really tries to put its thumb on the scale to try to make sure that that activity happens deliberately and not accidentally. Support for both public, patient, and family, as well as provider education around the importance of early recognition and timely treatment. And for hospitals, creating an honor roll recognition program, a voluntary program to be able to highlight those hospitals that have very strong outcomes or improvement or have programs that are noteworthy, as we heard about through from Dr. Sands at Northwell, one of many examples of hospitals and health systems that have put into place both structural and process and organizational changes to try to focus on improving sepsis outcomes. And then lastly, as the senator mentioned, you can't do these things without resources, so that the Act also puts $20 million of resources each year to be able to fund these activities, which we think is an important beginning point. Next and last slide, I just want to recognize both the people on this slide, my co-chair, and the folks who are part of the expert panel helping put together the Act. But we also, this represents the efforts of and input from many individuals and organizations, including the Stauntons, obviously Senator Schumer's office, and the important input and work of CDC, CMS, and AHRQ. And without all of that input and help, I don't think we could have crafted this in the way that we were able to do. So with that, I'll stop and look forward to our discussion.
Wonderful. Thank you, Foster. So we've got about 10 minutes for discussion here. Ray, I'd like to start with you if you don't mind, and then maybe have the panel jump in with questions for each other if they have them. But recognizing you're not speaking for the CDC or CMS, as you've said before, what do you expect of the timeline for the release of the new measures? When do we expect to see the details? When do we expect to be held accountable?
I can speak a little bit to that. As I mentioned, the final decisions, of course, for the use of these measures, especially in CMS programs, lies with CMS, and they have a timeline for how quality measures get gradually adopted, into their programs, so they can't just turn on the switch, and decide that, hey, in 2 months, we expect every hospital to report this measure to us. They have an on-ramping timeline to ensure there's enough time for adoption for among the thousands and thousands of U.S. hospitals. But what I will say is that behind the scenes sausage making process has started. So for example, for the outcome measure, it was submitted to the CMS measures under consideration list, which is the first step for getting on those lists for the use in quality measure program. So submitted last May. It's going to be up for discussion, I believe, in December and January. And then it'll also be put forth soon into the Partnership for Quality Measurement for that endorsement process. But without being able to give kind of more details, it is a multi-year process to get on, to have these measures adopted into CMS programs, which I think where folks expect them to eventually be used.
And one quick follow-up, if I could. Foster mentioned the Sepsis Act, including some focus on pediatrics. Do the current measures, as you understand them, have any pediatric focus to them?
So the hospital sepsis program core elements measure applies to all hospitals. And I'm aware of some other work, parallel work that was also a result of the funding that Senator Schumer mentioned at the beginning of this presentation, where there is work that I think we expect to be published in just a matter of months about new work on pediatric sepsis surveillance that is kind of also the first step towards building quality measures in the pediatric space.
One of the questions we have, and I'll direct this maybe to Aiken or Mark. What happens to SEP1 with this? And I guess, the reason I'm directing it to you, why do we care? SEP1's out there. It's a measure that has maybe some value. It is debated whether it has enough value, but why would we care whether it goes away or not?
I'm happy to start. Happy to start, and Dr. Sands, please feel free to fill in any detail here. I think from the perspective of hospitals, national measurement programs are an opportunity to focus attention on high priority topics. It does mean that as we're thinking about the full suite of those measures, we always want to be mindful of both the sheer number of measures on the list, as well as the amount of potential administrative effort it takes to collect and report those measures. As these newer measures begin to emerge, I think one of the things that we think should be on the table is potentially a phase out of things like SEP1 as these measures start to come online. Important to recognize that SEP1 has been in CMS programs for, I think, the better part of 10 years, more recently as a part of the value-based payment program. It may be that kind of inflection point where we have this emerging approach to measuring sepsis, especially the outcome measure that may encompass and drive performance even more effectively than SEP1. So that's kind of the broad perspective we have on it. But Dr. Sands, please.
Yeah, the departure will be bittersweet. We have been monitoring through KQMI, our internal data and analytics group here, the number of the patient outcomes where the 3 and 6 hour bundles have been maintained. And even going one level deeper, order sets resulting in the successful completion of 3 and 6 hour bundles. And what we've seen now for about 1.5 years running is that patients in whom the 3 and 6 hour bundles are maintained have better outcomes than patients who don't. So it's a best practice, sort of basics, return to basics kind of approach. And I'd be happy to see newer, more sophisticated monitoring. At the end of the day, it's really getting the patients assessed quickly and staying on the antimicrobial, blood cultures, lactates, all the basics that basically determine patient care. So it'll be a bittersweet departure when that time comes.
Other thoughts from the group or other questions from the panel? I've got a bunch of questions, but I don't want to dominate this. So what happens so step one is right now part of value-based purchasing. Do we expect the outcome measures to fall in there as well if we end up with multiple of these? How would that play out in the financial side of the impact of this? I mean, Foster, is any of that envisioned in the Sepsis Act, or is that all a matter of how things then move forward through the interpretation?
I think that, as folks on this will attest to from their own hospital systems and experience, that, what has happened over time is when the metrics are introduced from CMS or from elsewhere, they're very often, going through an initial phase of sort of testing it out and seeing what the issues are around just being able to report the measure. Some measures make it to an end of being part of a value-based purchasing program on the part of the federal government. Some don't. There's obviously been, a ton of controversy about which ones do and how good they are and how much that program drives improvement given all the other forces that are at play in hospital systems. But the act itself, to answer your question, the act itself doesn't envision or promote a specific outcome relative to these metrics, but essentially relies on the process that we've seen with other measures for other conditions to play out. And hopefully measures that are in fact robust, that do have a strong evidence base, and that are connected to, levers that can actually be understood and improved upon, like early recognition and delivery of antibiotics, for example. We'll make it into, all those programs, and that would be a net benefit. I see he is shaking his head. I hope that means you agree.
I was just going to add a little bit of context to your question, Martin. What tends to happen with measures that get developed and are being considered for CMS programs, if it's going to go into value-based purchasing program, there's usually a period during which CMS will ask for the reporting of the measure first before tying it to VBP. In part, that reporting process is intended to identify how the measure is working from a data collection perspective, to suss out any potential unintended consequences that might be emerging. Then I guess the non-technical term would be kind of a shakedown cruise for the measure before it gets tied to payment. Obviously I can't speak for CMS, and I don't know precisely what their plan is for the outcome measure or any of the other measures that are under development. I would imagine they would follow a phased approach that looks something like that for putting it into a value-based payment program.
Any other thoughts? Any other questions for each other?
I'll just add that, I don't think I got to it in my presentation, but I think part of the big hope with the sepsis outcome measure is that it can help incentivize innovation that helps move the needle. And that's going to look different from hospital to hospital. For some hospitals, that may mean really honing in on your SEP1 compliance and making sure those early detection and care processes are really down and nailed down and performing well. In some other places, that may be implementing new AI tools that we'll hear about later on today that help predict the onset of sepsis in some of your specialty populations, because there's the ability to train these models to the data that you get for your oncology population, for example. And so I think many of us have been in practice long enough to see the kind of frustrating course of sepsis, therapeutics, some promise and some setbacks, along the way. And we hope that having an outcome measure that really, looks at the entire course of the hospitalization can help drive innovation in that space as well.
Yeah, I just want to add, we're focusing to date on one outcome measure, which is risk-adjusted mortality. Obviously, incredibly important. You heard the congressman say how important it is to just be here and to have survived sepsis. But we shouldn't, as we all know, there are a whole host of other outcomes that are relevant, like getting back to your normal life and functional status. And we know that even for folks that survive sepsis, the morbidity outcomes are significant. So we hope this is the beginning, and the phrasing in the act suggests not just one outcome, but really the development of outcome measures that are relevant, that include but are not limited to looking at mortality.
Very close to the panel, Foster. Appreciate the work of all four of you gentlemen, both today and in your day jobs, and really thank you so much for a spirited discussion here on this. Very informative. Thank you so much.
Pleasure.
With that, we're going to move to our second panel. Trusted Messengers, the urgent need for a new paradigm for health communication. I can get up the folks here. We'll be ready in a few minutes here. Excellent. And I saw a couple of my panelists on the screen there before, if I see them here. But we're going to do this a little bit different than the previous panel. I've asked the four presenters to briefly introduce themselves, and then we're going to have Dr. Pantagini talk a little bit about her work to set the stage for then the ongoing conversation we will have from there. I also want to, April Chavez is going to introduce herself, but I want to point out that April, not unlike the congressman, is a sepsis survivor, and that she has been very involved in End Sepsis, where she's a board member. She's worked with American College of Obstetric Gynecology on Sepsis Obstetric Care Bundle, as a faculty member of Mama's Voices. I'm not expecting April necessarily to tell you all in depth about her as we come into this, but maybe start, and actually I'm going to call out Dr. Faust and then thank him in particular. He's here after having worked all night in the emergency department. And so we appreciate him taking the time from his early sleep schedule to be with us here today. So quick introductions from the four of you, and then Kristen, if you would really lead us off by talking about your important work here.
Good morning. Thank you so much for having me. I'm truly honored to be participating in this End Sepsis Forum. I have known the Staunsons for many years, and we've met several times. And I feel as though I know, or I knew Rory, even though I never did. So that gives you some idea of how I'm here. I've been following the development of sepsis measures for a long time, and the last conversation is one that I was dying to be a part of, just in terms of, let's get to an outcome measure. So I was watching with great interest. And I also, while I did work very, very late into the night, I did not, frankly, work until 7 a.m. So I'm on an off sleep cycle, but it's not as bad as it sounded. I write a newsletter called Inside Medicine, and I help as the editor-in-chief of MedPage Today. That is a online magazine or a news outlet that covers what's going on in health and medicine. And as such, I feel like I'm sort of on this on the border between frontline clinical care and public communication. And I also do research. So that puts me in a unique perspective that I think is probably why I'm here. I see patients, I see patients' families, I see the advocacy in person, and then I also see what we have to do to reach people outside, both before and also during and after patient encounters. So I believe that's why I'm here, and I'm looking forward to a conversation and really about communication, both in person and sort of remote, the online social media sphere that I think has become a really important part of that conversation. So thank you for having me, and I look forward to speaking to the other panelists.
Thank you. Kristen, how about telling us a little bit about yourself?
Yeah, thank you so much for having me here this morning. My name is Kristen Pantagani. My day job, like Dr. Faust, is I am an emergency physician. I'm currently a fourth year resident in the Yale Emergency Scholars Program. But like Dr. Faust, I spend a lot of my free time in sort of the online world. So at the beginning of the pandemic, I started a newsletter called You Can Know Things. And the aim of that newsletter, especially initially, was addressing the health rumors and myths that were circulating online and providing a simple and easy to understand explanation that was both a deep dive into the various rumors, but also was explained in a way that someone without any medical or scientific training could understand. And so I've been doing that for the last 5 years. I've also worked with Dr. Faust and his newsletter, Inside Medicine, as well as Dr. Caitlin Jetelina and her newsletter, Your Local Epidemiologist. But since I've been doing this, especially I'd say around year 2 or 3 after COVID, I noticed that a lot of what we were calling misinformation or inaccurate health information, and a lot of times could better be characterized as miscommunication in the sense that physicians and scientists and public health leaders were putting out one message, and it was understood within the medical community what that message was supposed to communicate, but a lot of times it wasn't accurately landing with the public. And so that's something I focused on a lot more recently, is not only addressing those rumors and myths, but looking at how we're communicating and why we see this decline in trust, and what we need to do to really do better and reach people more effectively.
Wonderful. Very much appreciate that. One of the things that I didn't include in the introduction to this panel is that in Rory's situation, there really was a breakdown in communication. Obviously, it was prior to some of the more current communication options being available. But I'm sure in many circumstances, families, loved ones, et cetera, miss having the kind of information they feel they can act on. And then certainly and we're going to come back to this after we get through the rest of the interest. Rachel, if you could tell us a little bit about yourself and your work, and we've specifically asked Rachel to be part of this to address some of the evolving, or at least be a commentator on some of the evolving aspects of generative AI in this space. So Rachel?
Absolutely. Good morning, everyone. Rachel Spooner. Currently, I'm the Vice President for Strategy in the Center for Virtual Health at Northwell Health, which is a long way of saying I work at the intersection of clinical care delivery and digital tools. So where our patients are, where our clinical teams are, and all of that digital technology that interacts in those spaces. My background is in improvement sciences and change leadership. So this is sort of a perfect place to discuss all of those different aspects and how they come together to either improve outcomes or kind of take us away from those outcomes that we're desiring. Additionally, I work with the Endless Frontier Labs as a business coach and advisor. And these are startups that are in the early stages, either Series A or seed funded startups. And they're really pushing the boundaries of where we may be able to go in the future of healthcare delivery and healthcare enhancement.
Wonderful. And April, and we have a slide or two from you. So if we could move to April's slides, and April, tell us a little bit about yourself and your journey to being here somewhat voluntarily, but against your will originally, since you didn't volunteer to be sick.
No, I didn't want this at all, but it's almost been a blessing in a lot of ways. I've kind of found my passion for advocacy work. As Dr. Dorfler said, I am not a medical professional. The reason I'm here is I am a maternal sepsis survivor. About 8 years ago, I had a normal delivery of my son, thought everything was fine, and then things started to kind of head south. But when I brought up my symptoms with my care team, all of which were consistent with sepsis, I was kind of just brushed off and told that I was an anxious new mom. It was normal to feel this way after childbirth. I had a long labor, so they told me I was just tired, and every symptom I had, including fever, was basically dismissed. And so I was really interested in this discussion because I use AI every single day in my professional life. I work in marketing and communications. So there's a lot of value there, and I see how people are using AI to interact with information. But in my case, I think AI could have been a powerful tool when that human error occurred to have a different outcome in my situation. So I've really dedicated the last 7 years of my life to helping to improve outcomes. And I'm really, really thankful to be here and be part of this discussion. I really think AI is a great tool, but we need to figure out how to partner it with the people that really make things happen. So thank you for including me in this discussion today.
Thank you so much. Dr. Pantagani, we're going to start with you to really set the stage then for the rest of this. The stage is yours.
All right, yeah, thank you so much. So when we talk about health communication, what comes to most people's minds first is communication within the healthcare system. So whether that's a patient talking to their doctor in the doctor's office or in the ER or in the hospital. And that's certainly a critical part of health communication. And it's received, at least sort of in the academic world, it's received the majority of the focus. If we look at like the Healthy People 2030 goals, health communication, improving communication within healthcare systems is part of the goals. And there's certainly significant room for improvement. And I don't want to suggest that, we do have training in medical school about how to talk to patients and breaking bad news and things like that. That certainly doesn't mean that we've mastered it. And there's a ton of issues to address there. Many of them systems level issues like overcrowding in the ER and things like that. But I want to draw a distinction between health communication in the healthcare setting and then what we're seeing is influencing patients more and more, which is health communication in the online world and new media. So like social media and AI tools, and still, of course, the legacy media that we see health information there as well. But we know that social media is becoming more and more where people are getting health information. I believe the statistic is now about 50% of people get at least some of their health information on social media. And so when we think about the communication tools and the style of communication for that inpatient one-on-one encounter with the patient versus communicating on Instagram, those are entirely different skill sets. And I went through both medical school and graduate school, and I had practice, communicating with patients, and I got feedback directly on that. I got absolutely zero training in how to make an Instagram reel and how to raise awareness for something like sepsis and how to do that public style communication, but it's becoming more and more important. And so this is something I recently wrote about, an article in the New England Journal of Medicine, and the article is called Training Health Communicators, the Need for a New Approach. And it highlights this sort of gap in training we have in the sense that medical schools, graduate schools, public health schools, nursing schools, we're not equipping students and clinicians to be ready to communicate to the public in this new media environment. And that's something that's really missing. And unfortunately, what we see then is people who don't necessarily have the training or the background are the ones doing the communicating. And oftentimes, they're not communicating accurate information. So if we want accurate information to dominate, we need both the people who have that training to be speaking, but they also need the tools to be effective in this new media environment. And I want to bring up an article that was recently put out by the Carnegie Endowment by DeResta and Kleinfeld. And they talk about, their articles beyond just the healthcare world, but they talk about this shift from legacy media, so like, kind of what we think of, TV and the traditional media outlets, to new media, which is social media, YouTube, and AI. And this shift is occurring in all areas of society right now. And the institutions, the style of communication that worked in that old media era, it completely flops online in the sense that on social media, what works is not talking heads like you see right now of me, but more engaging and storytelling and personal style communication. And that's the exact opposite of how we're trained to communicate as academics. As an academic, I'm told to take my personality out of it and just talk about the facts. And if you do that in the new media world, the algorithm is not gonna favor you. So we have both the problem of how do you communicate to the public and getting that training across the medical disciplines, but also how do we even navigate the new media environment and teaching people that it's okay to show your personality when you're talking about a healthcare problem, and you can be both a doctor and a person and engage with people that way. So I think this is especially important for when we think about sepsis, of course, and I think we're going to talk about the inpatient interaction between patients and providers is critical, but also thinking about just raising awareness generally about what sepsis is and what to look out for and when you should go to the hospital. And that's not something easily solved with one-on-one communication. If we think about people go to their primary care doctor in that 15 to 20-minute visit, they don't have time to educate them on all these different diseases that ideally they would know the symptoms to look out for. But it is something that we could address in this new media environment and raising awareness. So with that, I'll hand it back to Martin.
Excellent, thank you. April, let me pull you in. What are your thoughts hearing Kristen? If you don't mind, let me use first names here, just to straightforward. But
that's fine.
What are your thoughts, April, on hearing Kristen's conversation here?
I think it's really interesting. As somebody who uses social media and AI every day, I think we've talked about this previously. I don't want to go to a website and have to read 3 pages of something that I don't understand and have to go and look things up. As a patient, if I just Googled now just to see what would come up, like, what is sepsis? The first thing that comes up is an AI summary. That is what people are used to. You scroll down a little bit, there's 3 videos, all under 2 minutes, that tell me what sepsis is. That is what I have the capacity to digest. I'm busy, as most people are these days. I think we really have to meet people where they are, and if we don't find a way to marry the two, things will get a lot worse, because then we have the unqualified people out there that are pushing out the information that's not correct, and that's where we're going to get into trouble. So I think we have to be really intentional with providers to get them to understand the value of AI and social media and things like that, because that is what the majority of people want these days. They don't have the time to dive into things that they probably don't even understand.
So one of my children is in marketing. April is in marketing. Ezra Klein has recently talked about the attention economy. Kristen, you talked a little bit about all the different ways we have to reach people and how physicians, other care providers are not necessarily skilled in how to use the tools. But then we also have this other component to it of, all the stuff coming to us. I'm wondering, Jeremy, Rachel, maybe jump one of you into this. How does this fit with the, I have lots of good information out there. It might even be well presented, but I don't have the, April just said, I have 2 minutes for this, I have 2 minutes for that, yet help me out here, jump in.
Sure, I'd love to. Because as I listened to Kristen and April talk, I thought, okay, now I know what I want to say. Thank you. Which was that I'll start with an anecdote. Actually, Kristen tells me to tell stories, and even though I consider you a mentee, you're always mentoring me back. It's like great. And I'll tell a story. Yesterday, I went to lunch with a friend, and I ordered Korean food. I had bibimbap, and I had not had that in a while, and it was great. I went on the way to the hospital. I looked at my phone. I was in the back of a lift, and my phone showed me a slideshow from my trip to Korea 11 years ago. It was listening, and then I opened up Instagram, and among my reels was a food influencer talking about South Korean food. Okay, this is what happens. So someone's going to say, gosh, I don't feel very well. I don't feel good. Maybe I should go to the doctor. They're going to open up TikTok and they're going to say, oh, you have a fever and you feel like your heart is racing. Why don't you take this vitamin C and you'll be fine. So, or this remedy that I'm selling here. If you just click this, get a 10% discount. And so what I think we need to do is, as both of you I think said, is to go where they are and to flood the zone with information so that when our phones hear us and serve us what they think we want, that a big huge part of that is deflecting against the misinformation. Because one of the most important things we know is, hey, most of the time, if you seek care, you're going to get good care. Now, there's obviously, we can talk about when that goes haywire, and where the miscommunications are. But one of the most important thing is recognition and evaluation. And I think that the place where we are in this new era at risk of losing people is at that moment where they're going to their phone for information.
Thank you on that. Rachel, I'm going to pull you in here. Part of the dialogue that I've paid attention to on LinkedIn, bringing in another social media site to the conversation here, is amongst physicians in particular, but I'm sure providers, where the patient comes in, and this is more the office space, so I'm curious, Jeremy and Kristen, whether you see some of the same thing. I've got 15 minutes to see the patient, and they've got 10 minutes of questions from the large language model, synopsis they got when they Googled or something else. And I don't have enough time to dissuade them from spending all of it on that. What are you seeing with the groups? I mean, you're at Northwell, you're working with physicians around change management and the adoption of technology. How's all this stuff playing out?
Absolutely. So, to April's point, people aren't looking for static documents, right? They do not want to go and be forced to read something, especially something that is written for either a medical or kind of a very specific audience. They want something that feels like a conversation. And this is why they're turning to ChatGPT or other AI bots. And I'm not going to say that that's problematic in and of itself. The challenge happens when, we have the wrong kind of information coming back through that large language model. They can be incredibly good, but they also can have pretty significant limitations. And to the point of, as we are having conversations and we know that everyone's time is limited, maybe being able to pre-engage with our patients and have them engage with a large language model that we've selected via an interaction that comes before that appointment. Right. So we have a little bit more control over the information that's being surfaced. One of the beautiful things about these AI modules is it feels very conversational. It often responds in the way that you talk to it. So and this is both voice and text. I've had the wonderful experience of shifting between my very New York centric, fast speech pattern and a more slow, soft Southern speech pattern, and the AI will mirror me. And to see that happen in real time, where it doesn't matter where you're coming from, you feel both heard and seen. And then you can take that into an interaction that allows the person that is engaging with you to be well informed about what you know, and you then have the opportunity to re-engage perhaps after the visit to say, can you explain this to me again? Or I don't really think I got all the pieces to it. What were those instructions again in words and ways that I can understand? So I think as we're starting to see the enhancement of some of these language models, not everything needs to be a large language model. Sometimes small language models are actually the way to go. And those small language models can be very specific and pull from data that is being adapted and changing that help to mirror our patients where they're starting.
You see Rachel and Kristen both shaking their heads, or not Rachel, April and Kristen both shaking their heads. Yes, either of you wish to comment or extend that conversation?
I love the idea of giving them a tool that they're familiar with, an AI tool that people probably use every day beforehand. Because I think that's why a lot of people are turning to things like ChatGPT, is because immediately when we start to feel symptoms, we start the Google, we do all those things, and it's really hard to understand. So then we plug it into ChatGPT and tell me about this. Tell me what questions to ask my provider. And I understand you only have 15 minutes with your patients, that's exactly why we do it, because we know we're going to be hurried in and hurried out sometimes. So you might feel a little bit more empowered as a patient having at least a basic understanding. Now, whether that understanding is accurate or not, that's the problem. But it gives the provider an opportunity to debunk what's not true. And I think the providers themselves have to be open and not just dismissive to AI, because then it's kind of a battle between, well, this is what I read on the internet, which is what everyone believes to be true these days. And this is what somebody who may be older or doesn't understand, but really they're the expert. So it's kind of a battle between the two, unless your provider says, okay, tell me what you understand and ask me these questions and let me tell you from a medical perspective what it is. So they really have to work hand in hand.
Kristen?
Yeah, I think that from a clinician perspective, I think that the chatbot both represents an opportunity and a challenge. And the opportunity is what everybody's been mentioning in the sense that it gives a very usable, easy to understand way for patients to get information. The challenge, as others have mentioned, is that that information isn't always accurate. And the thing about the publicly available large language models is often they have a hard time saying, I don't know. And that's something that often gives a false sense of certainty. And so it can present a challenge when, like you're saying, April, when you go talk with the clinician, is sometimes there's this certainty communicated from the chatbot that doesn't reflect reality, and that can create a challenging conversation. So I see it as yeah, like both an opportunity and a challenge. And I think the solution going forward is going to be creating the tools that are specific for specific problems. So in the sense that training the large language models to be cautious and to put caveats in there and to communicate that uncertainty, which is something we talk a lot about in sort of the online communication space from trusted messengers. Is one thing we need to do a better job at is communicating uncertainty and saying, when there's a range of possibilities and how we're going to address that. And so I think as the technology advances and we're able to do that, that's going to be able to serve patients even better.
Rachel talked a little bit about how the large language model, and I'm guessing small language models, which I haven't done any work with, have a little bit of the same characterization where they do mirror you to a degree. They also can be somewhat sycophantic. And so if I am believing that the COVID vaccine is the basis, is the reason for my kidney disease. I don't have kidney disease, but I'll throw that out there as a hypothetical. And I'm continually pushing on the large language model to explain to me how the COVID vaccine gave me kidney disease, or why the measles vaccine is going to cause autism in my children, or other sort of things. How does that? And I guess Jeremy, you're shaking your head. Kristen, you're closer to your training. If I am in training, how am I dealing with all of this? And to your point, Kristen, and again, I'm happy to hear from Jeremy as well, and if any of you on this, how do I put all this in context as you want me to learn all these new things while I'm also learning the newest genomics and proteomics and other sort of technologies? One of my sons is a physician, and we often talk about the fact that a huge amount of what he's learning didn't exist when I was in my early education. How does this all fit into the ongoing burden on the shoulders of folks trying to do their best?
Well, I think as a person who practices emergency medicine, but also teaches it in real time, I am now far enough into my career where I hate to say this, Kristen, the fun part is not teaching the medicine. The medicine is kind of boring. I mean, it's not boring, but it's like, I could be replaced with that. The interesting part is these other challenges, and one of which is, oh, how do we actually practice medicine in 2025? Because the textbook was written in 2020 or 2015 or 2000 or 1950. And so the fun part is, hey, how did like we talked about this, like breaking bad news or breaking any news or asking the right questions. It's that engagement. And you were talking about Rachel, 15-minute encounters. That is a never happening in emergency medicine outside of the critical care cases we have. And in those cases, we're much more like auto mechanics than we are like psychiatrists. We're just working on the body. For the most part, our interactions that are talking to patients and their families is closer to 15 seconds. It's not quite 15 seconds. Maybe but it's a few minutes. And so I love training that part of it. And I think a big part of the way I think about this community is with advocacy, a lot of times it's really engaging everyone in the room. And that's the family member who's with the patient or some other person who's with them. And increasingly it is that other voice in the room. It is their phone, right? So how do we engage that? And how do we take it in and not be not come across as, oh, how dare you ask a question or you question my expertise. No, how do we welcome that into the conversation and let it develop in that way if that's appropriate, or if it's not, how do we get the train back on the track because we sense that would be a little bit of a derailment here. So a big part of, for me, and quite frankly, the joy of working with residents and students is the challenge of this. And I could not agree more, Martin, that one of the big challenges is these conversations are absolutely now the front swing of a backswing. And the backswing is they looked at GPT or they looked at AI or or TikTok. And in that backswing, there was, as you said, it gave us what we wanted from us. Oh, it was a sycophant. It told us exactly what we wanted to hear. And so we have to address that. So I think that the training, the next phase of training needs to be, how do we we kind of sort of thought about this with Dr. Google, but it's next level with Dr. AI and ChatGPT. How do we harness that energy and interest towards better care and not be defensive and also not get derailed? Because at the end of the day, hopefully if we're doing our jobs, we're the ones sort of guiding where things could go. But you know what? Sometimes like they say, if you see something, say something. Well, that will change what we do.
So I'm going to call out the lack of color in my hair and point out that all of this digital technology has evolved from nothing to what it is today during my career. And I'm going to do that to call out that my generation and slightly behind me are still in the front lines of care in many places, and really raised to any of you, but Rachel and Kristen, how are you dealing with, and Kristen particularly as a quote trainee, how do you deal with a non-enlightened Jeremy or Rachel in the part of transformation activities in the health system? April's looking for all of us to meet her where she is, and that's not being critical of that, it's simply calling that out. And yet I'm nowhere close to where she is based upon my history and my training. How do you address this within the scope of folks like myself still being on the front lines of care and yet responsible as novices within a communication space like Kristen, you're promoting?
Yeah, absolutely. I think the first thing is, from what I've heard, there's this feeling of people who didn't grow up as much with this technology that it's just not for them, and that in promoting, that we need to engage in this new media, that's trying to push people out. And that's the message I would say is absolutely not true. I think the solution is not to, like, we need the expertise of the people who have been doing this for decades. And people want to hear from them. Like, people want to hear from doctors who've seen thousands and thousands of patients. And so the solution is not to say, okay, this new media stuff is just for, my generation and Jeremy's generation. It's for every generation. And the solution is simply to communicate or give the training and the skills of how to engage in it effectively.
So Rachel, you've dealt with me and people like me for quite a while. What's your take on changing people like me?
So I think Kristen makes some excellent points. This is not about replacing expertise. And I think that's often the fear that comes with I'm communicating in a different way. I don't know what this is. The way that we've seen it work quite well is actually to pair up, younger physicians or prescribers with people who have a lot of expertise and make it a little bit silly and fun and remind them of the joy that comes from being a new practitioner in something, right? They know the medicine incredibly well and they've had tons of experience. And so kind of flipping the script of, I know the media really, really well. And so let me show you the medium more accurately. And you share the medicine that you know, and do it in a really engaging way. So that has been incredibly helpful. Also, just having people interact with some of these things is relatively awe-inspiring. Some people are like, I didn't think that this would ever happen, and this has happened quite quickly. And to engage them just in the, what if you could do this more easily? What if this allowed you to spend an extra 10 minutes, virtually with your patients? How would that make you feel better about the way that you're delivering care? I think I read somewhere that, as we're starting to see this next, generation of physicians retire, we're losing an immense amount of information because so many people, right? We haven't seen some of the either diseases or incidents that were at the very beginning when you were training. And so the only way that we know about it is through textbooks or any type of other encounter where it's not something that I saw in real life. And so trying to hold on to that information, whether it is through stories, because stories are so powerful, or other ways that we can generate through AI videos and other things like that, could be an incredible way to hold on to a lot of this information that is going to disappear because we're just not seeing the same diagnoses come through.
One of the things about large language models in particular, but is also prevalent throughout a lot of healthcare communication, is what appears to be certainty. The large language model is telling you this is. Again, I'll call Kristen and Jeremy in particular in this as the frontline physicians. You deal with a lot of uncertainty. April is in your emergency department or in what used to be my ICU. I don't know all of the answers, but she wants answers. How do you address that? And then I'll come back to you, April, after we hear their response and how you feel about the communication of uncertainty when you are the patient or it's one of your children, your spouse, your family members, et cetera, because you want certainty. Thoughts?
Yeah, so the way I try to address this, and it's certainly challenging, but at least in the one-on-one patient encounters, is to set the framework that almost nothing in medicine is 100% certain. So even the gold standard tests for different diseases have some level of error in them. And I think it is challenging because a lot of times, we do the test, we get the results, and we say, oh, it's not that. And we can say with a high degree of certainty, you don't have a blood clot in your lungs. But there's always the theoretical chance of a false negative. And so I think the trick is to narrow in on what is the patient's specific concern, like what are they most concerned about, and addressing the range of certainty and possibilities around that specific concern. If we, like Jeremy mentioned, especially in the ER, we have unfortunately very little time for the one-on-one communication, just because there's so many other critical patients and other things drawing our attention. And so I don't think it's realistic to address, every single lab value and every single test and talk about the range of uncertainty for every single thing, but instead focusing in on specifically what is the concern and then giving an accurate assessment of what is our degree of certainty, and then If we're wrong, like in emergency medicine, we always talk about return precautions. We scanned your belly, we didn't see anything wrong, but if your symptoms persist, if you spike a fever, if you can't keep food down, these are all the things to look out for that you need to come back to the ER. And that also kind of addresses that uncertainty in the sense that we can rarely say with absolute 100% certainty of anything, but we can say with probabilities, and then we can talk about what we do if the expected outcome doesn't happen.
I would add that we have sometimes in emergency medicine, particularly on the front line, a slightly different agenda than the patient. Sometimes the patient wants a diagnosis, which makes complete sense. And as emergency physicians, we're hoping not to give you a diagnosis because we're really good at diagnosing things that are dangerous in the ER, and we're not so good at diagnosing things that some other expert could diagnose if it's not time dependent, meaning we don't have to do it this hour or even this week. So that we always start from that different agenda. And so patients come with questions, and I'd like to just, so what I'll add is, and I know we don't have a lot of time, but I think one of the biggest things we can do is answer our patients' questions. And some of that comes from information from social media, and some of it comes from information that actually we're giving them, we being the hospital, being my chart, your results are in. And so I'll tell a quick anecdote. I saw something online the other day where someone said, "Oh, they discharged my sister, and look at her lab values, and they're all flagged. This is weird. This is weird. This is weird. This is weird." And I looked at it and I said, "Well, I don't know if that patient was sick or not, but I can tell you all those lab values were kind of meh. They didn't really add up to much." And so they were freaked out, which I totally understand because there's an exclamation point next to it. But I don't think the doctor necessarily would have, depending on how the patient was looking. And this is where the patient advocate comes in, saying, "Well, actually, doc, hour ago they were fine and now they're kind of like drooling or something, like literally." So we need to really act on that clinical data. So I think that one of the most important things on the advocacy side when you're with a patient and you're in that patient encounter, or you are the patient, is just to make sure that your clinicians are not missing information. There's misinformation, like, oh, or misinterpretation, like, oh, your blood count says this. It's a lot less likely that we will misinterpret something. It's much more likely that it's missing from our brain, that we don't know about it yet. And so bringing that to our attention is such an important thing to do, because then we can actually say, okay, yes, I knew about that, and here's why that's okay. Or, oh, gee, I didn't know about that. Let me think about that for a second, or let that that necessitates another test, or maybe it doesn't. But let me tell you why. So I just on on this idea of certainty, I think the one thing that our phones can do that can really help us as patients or as patient advocates is just to make sure, with all of the incredibly high stress that Kristen and I have with the number of patients coming in and the complexity of the care, is to just, hey, we're not above being asked, hey, did you notice that one thing? And if the answer is no, let me check it out. And if it's, yeah, I did notice, and here's why it's okay, most of the time you're going to be in great shape. I think answering patients' questions is really important. And the most important one is you asking us, were you aware of something? Because things change and we cannot possibly keep up with everything in real time.
April, I'm going to come to you as the last commenter here in this panel. You've listened to a lot of good conversation here, and I'm curious, A, just broadly your thoughts, and B, more focused. How does any of this, if it does, change how you see your advocacy role?
It certainly makes me think about all the challenges that doctors face, for sure. Because to me, as somebody who is engaged with social media and helps clients with social media, it sounds easy. But then I step back and I think about, if I ask Martin to create an Instagram reel to talk about something, what are we really going to get here? So interesting perspective for me, because it's kind of the world that I live in. But I do think the biggest takeaway I have here is, with all of these tools that we're giving people, we have to give patients an opportunity to ask questions and be open to those questions, whether they come from AI or wherever they're getting their information from. I think we have to focus more on a dialogue with patients and providers. I think as far as changing my advocacy work, I'm really interested in AI and I want to keep exploring it and keep figuring out how we can marry the two. I know, Rachel, you mentioned partnerships between physicians, which I think is amazing. I've seen a lot of those on TikTok where it's maybe somebody a little bit older partnering with somebody a little bit younger to disseminate information, which is really great. But I would also say reach out to your communications departments, your marketing people in your hospital. That is their role. And if you can get them to understand something really big and medically complex, they'll help you disseminate that information in a way that if they can understand it, your patients can understand it too. And yeah, it's just been a really interesting topic.
Well, I want to thank all four of you. I've enjoyed this very much, and I hope our audience has both enjoyed it and learned from it. Very informative. And again, on the part of NSepsis and the forum, thank you so much for your time today. This is as a housekeeping, we are going to have to switch the link by which you come into this for the second two panels because of the separation of these first two have CME associated with them and the second two do not. So please stay with us and come back for the third panel. The link will be up immediately. I believe we're going to have a short pause before actually coming up with the start of the third panel, which is going to be hosted, moderated by Dr. Nirav Shah, and I'll let Nirav and I'll introduce at that time. So again, thank you all so much for your time here so far this morning. I look forward to the rest of the forum.